Hello, I'm Alex Quistberg. I'm an associate research professor at Drexel University in the Department of Environmental Occupational Health, as well as at the Urban Health Collaborative in the School of Public Health. And I'll be talking today about case control study designs as a follow-up to the other lectures in this series from the Case Control Studies on Injury Risk and Interventions in LMIC's program. So we'll go into a number of aspects of case control studies with applied examples from some of our own research so that you can hopefully learn from those. And if you have questions, we can certainly answer those later on. So the two applied examples that we'll go throughout most of the presentation on are one based in Lima, Peru, and another in Delhi, India. The Peruvian study focuses on pedestrian collisions and the risk of collisions based on road infrastructure. In Lima, at the time of the study, there was close to 12,000 pedestrian collisions per year, and about 1,000 of those were fatal. Um, a walking environment there was very complicated and mostly favored motorists over pedestrians. And so the question was, how can we identify street feature risk factors? And a case control study design was the answer to that, to understand the relationship between a given uh, road infrastructure feature, such as sidewalks, and the risk of a pedestrian collision with a motorist. In India, a similar study was also engaged, but focused on bicyclists. Um, So about 3% of road traffic deaths in Delhi are bicyclists, and cyclists are 40 times more likely to be killed than car occupants per kilometer traveled there. And so the question they wanted to answer was what road characteristics and traffic volume impact cyclist fatality risk? And once again, a case control study was the study design that was appropriate for answering these questions. So what is a case control study? So in a previous lecture, you learned about different types of study designs, and you should have learned a little bit about case control studies from that. But especially in a case control study, we're working backwards, retrospectively. We have a set of cases of individuals or locations or units that have the disease or condition of interest. In this case of this program, we're looking at injuries as outcomes as the disease or conditions. And we're looking for controls that don't have the disease or condition. And then, as part of the case control design, we go backwards to determine if they were exposed or not to the factor of interest. We then evaluate the likelihood that disease or condition is associated with that exposure, which gives us some ability to causally determine the relationship between that exposure and outcome. So why should we do a case control study rather than some of the other study designs that we saw examples of in our previous lectures? Well, first off, case control studies can help us determine etiologic hypotheses. So, like, what is causing our outcome of interest? And they're more efficient for doing this in many cases because they require small numbers, and they're particularly efficient for outcomes that are rare. So let's say like less than 10% of the population might have this outcome or disease in whatever study period that we're looking at. Typically much more rare than that. And the relationship of interest we want to look at might be difficult to capture prospectively because of the number of individuals that required to capture the cases or observe the case happening, or collecting exposure data for a large population, many of whom will not get the outcome of interest, is expensive or difficult. It's also, for diseases that have a long period without being diagnosed or being observed or uh, emerging and have a long latency period, case control studies are also particularly useful. In the case of injuries, that's usually not the case because usually at short events that cause them. but those types of events are also well suited to a case control design. And finally, case control studies also allow us to examine multiple risk factors of a single disease with the same group of cases and controls. But we can only look at one outcome. So the first step in any case control study is identifying the cases. A case or the source population, but typically we already have a source population in mind where we're getting cases from. It might be the city that we're living in or that we're studying, or maybe a hospital. And that kind of defines our source population for us, but we'll talk about that in a second. But often we've seen cases, and that makes something that we're interested in, and so we want to define and obtain those cases for our purpose of study. Um, so we either need a complete census of all cases, or at least a representative sample of them for case control study. We want to be sure that for the population of interest, that we identify all people that have developed that outcome of interest within our specified time period. And we want to include them irrespective of their exposure status, of whether or not they've been exposed to the thing of interest that we're studying. We need to define those cases very specifically so that we only include those individuals that meet those criteria, and that we completely obtain all cases that meet those criteria where possible. If not, we can do a representative sample of them, which might be sometimes more cost effective. So some examples of where we might identify cases from our police reports. Lots of road traffic safety studies or crime studies use police reports. We can also use patient records from hospitals and clinics. We can use insurance records, vital registries for fatal cases, or we can look at other secondary sources that might provide information about our cases besides these, of course. So when we're thinking about our cases and identifying them, we want to consider, as we're constructing this study design, of ways of biasing our information that we obtain about them. We can think about differential information bias, where the accuracy of the reporting between the cases and controls can differ, which is a form of recall bias. Or there's non-differential, where the accuracy of the recording of information is dependent on the interviewer or the study team. Or it could be impacted by things like missingness of data, so maybe we don't have all the information we need, or if we're mismeasuring things where we have measurement error. There's also another aspect of this that's known as confounding, which I'll talk about a little bit later in this presentation. So two strategies we can think about for including cases in our study are thinking of all prevalent cases or all incident cases. So when we're thinking about all prevalent cases, we're thinking of anyone that's had the outcome of interest. So if we're looking at all injuries, these are people that, for an injury, it's usually like a short-term event, might have long-term consequences. But we can gather a number of cases that are happening from retrospectively from a set of data. We might not know exactly when the disease happened, but in the case of injuries, we typically, because it's once again a short-term event, we typically know when that disease or outcome happened. And we're using that to establish an exposure-disease relationship. So we're looking back in time to see what exposures at the time of the injury might have led to that happening. We could also look at just incident cases if we don't, have the resources to go look back in time, or we're prospectively collecting things. So sometimes with hospital records, we might have cases coming into a hospital, like an emergency room, and we can recruit them into the study, and we might recruit them over a specific time period. And then obtain our controls, which I'll talk about later, for those cases. So when do we want to exclude cases? We want to make sure that any exclusions that we create are equally applied to cases and controls. Otherwise, that once again can introduce bias into our study. So, for example, sometimes because of the way we have to collect data, we might have to exclude difficult to reach areas. So if they're really rural, remote areas, that might make it difficult to collect data directly from those locations if we don't have, the money or resources or time to visit all those places. In some urban areas, there might be dangerous areas for study staff that might be best not to visit because we're afraid of being victims of crime or having study equipment stolen, things which some of us who have done this work before have experienced. Or the time of day might be difficult also for study staff to work with. So if it's something late at night, that can also create dangerous situations for study staff, particularly if we're doing something for road safety, where the conditions might not be safe for us to do the measurements we need to do during the daytime. Um, and then if there's language differences, particularly if we're trying to interview people that have been injured to determine, some information from them about their exposure or other characteristics, and we can't, you know, um, have a dialogue with them because of language differences, then that, of course, would be a reason for exclusion. On the right is just an example from the pedestrian study in Lima of how cases were identified and then excluded, depending on different stages of the study. So an example of these two studies, in Lima, Peru, the pedestrian motor vehicle collisions were located from police records. They were specifically from September to December of 2010, and they had to occur between 5 a.m. and 8 p.m. to be eligible for the study. In the case of the India study, the crash locations had to be within Delhi or Haryana and within 5 kilometers of Delhi's geographic boundaries to get to the peri-urban area. And their study time of eligibility was 5 a.m. to 10 p.m. So next step, which often we might also, like I said, might have done this earlier, but the source population is an important key part of identifying of a case control design in order to identify cases and controls appropriately, because both of them have to originate from the same source population. So some examples are we might be population based or geographical, they might come from group membership, maybe healthcare setting, from licensing records or insurance records or employment records. And by population-based, we mean the population is defined before the cases are ascertained. So we've defined, some population of a city as where we want to do the study, and then we might refine that in some way as we're setting up our design. If it's not population-based, like maybe we've obtained a series of cases in a hospital setting, and we have to determine, like what source population we want to use for those, or maybe we have, a number of hospitals, or maybe records from various police databases, and then we have to determine, well, what is the population that these originated from? So who is at risk of ending up in these databases that we're using, basically? And so if the cases aren't from a definable source population, then that could be problematic because then how are we going to choose our controls? Because the controls have to be from that same population. Otherwise, if we're including people that are not at risk for the disease and not from that original population, then that can bias our results. So for example, if we are choosing cases from people who have experienced healthcare, like emergency room visits at some clinic, then we want to be sure that the people we're selecting from among that hospital or clinic are people that uh, would be seeking care from there normally, and would show up there the same way as a case would if they were to have an injury. Um, we also have to note, there could, if we're choosing, people from differing locations based on like hospital use, maybe we have multiple hospitals we're drawing our records from, that could be a problem for differing exposure among those receiving healthcare from different places just because of who is visiting those different places. And so defining that study population gets more complicated. So for an example of our two studies, in the Lima Peru study, the source population, were considered, the population of Lima or those that were using the roadways there. But really the true study population were crossing areas at intersections and mid-blocks throughout the city. So they're really the roadways that were the subjects of the study. Similar in India, while people were used to identify the locations, the road segments in the peri-urban districts were the source population. So once again, controls must come from the same source population or a population potentially with the same distribution of exposure to the population of cases, but that can be difficult to measure if we don't know the exposure levels before we conduct the study. So it's usually best to use the same source population. Um, and though we don't use everyone in the source population, that's not the point of a case control study. We want to make sure that we select a representative sample of them, through like a random selection. They also should be at risk for the outcome, so they should be at risk of being injured. So in the case of these two studies where we have road segments of different types, they should be at risk of having a pedestrian collision or bicyclist collision, a fatal bicycle collision. And so we want to make sure that these controls are identical to the cases in the distribution of some characteristics um, that may have some likelihood and influence of exposure. Um, and we want to make sure that we can measure exposure accurately and identically across cases and controls. Because if we're measuring them differently, then that produces the risk of bias. And we can minimize selection bias of our control selection by omitting controls with conditions associated with exposure. So, um, if we were in a hospital setting and we are looking at, road traffic injury victims, we'd want to exclude people that could be at risk of our exposure of interest if it were like to be like some sort of neighborhood characteristics. So maybe, people that were victims of assaults, maybe there's some shared characteristics there that we wouldn't want to include them as controls. And we want to ensure uh, we don't want to try to avoid getting controls that have the exposure. We want to make sure that they're that we are including people regardless of their exposure status. We want to reduce missing data. We want to ensure that they don't have the condition. This is kind of a special case of injuries because, especially if we're looking at road traffic safety, or things that have like a location-specific type study, like the road segments in both examples, where they can have multiple collisions over time at the same location, and that's okay. As we'll explain a little bit later, there's a way of considering sampling these locations where uh, you can focus on the time of exposure and not just overall exposure or not, or overall outcome or not being present. As mentioned, yeah, we should randomly select our controls when possible. And so some of the alternative strategies we can use for control selection, I'll talk about a little bit later, but we can use risk sets and incidence density sampling. We can consider other designs that are related to case control, like a case crossover study, a synthetic control study, a nested case control study, or a case cohort study. I'll talk about those later. So these are just some potential sources of controls. You can look at this in more detail later from the slides in the paper. I'll just have a few specific notes about some of these sources. So for one, hospital and clinic-based controls. This is where we're identifying people who, had they developed the disease or illness, they would have received care at this location. Those are appropriate controls. Sometimes you might get people that show up at a hospital because of some other reason that they might not normally attend, go to the hospital. Maybe they don't live in that city and they just happen to be visiting. And so you have to be careful of including some of these cases. So maybe you need to set up some criteria for people that are residents that have maybe visited that hospital before, and not just like one time. If you're among your control selection. As we mentioned earlier, they should have conditions that they're being attended for at that hospital that are different, that are not related to the exposure of interest. So maybe cases of cancer, or some other specific condition might be appropriate controls for injury studies, depending on what the exposures we're looking at. Also people maybe were like evaluated for some injury outcome, but then they were confirmed not to have the disease of interest. So maybe there's someone looking at concussions, And if someone's determined not to have a concussion, maybe they're an appropriate control if they meet the other criteria for that study. Um, and so, the problem with hospital-based controls is that they may not represent the population for which cases arose. So you have to be very careful when you're choosing those controls. Um, we can also consider selecting from controls that are linked to the cases in some way. So these studies might recruit relatives, friends, or neighbors of a case. And the advantage of this is that they are typically more convenient to get than the general population. They can be lower cost because you have to expend less effort to recruit them. And they typically have a higher participation rate than the general population. But they can be too similar to the cases and exposure status. So sometimes there's sibling studies or twin studies that it's a kind of a natural match between people for certain outcomes and exposures, but because they maybe grew up in the same household, well, then they're going to have very similar exposures most likely, and so finding differences between them will be a challenge. And also, these people may not represent the source population of cases very well. An example of road safety, if you were to focus on a specific crossing at a given intersection, in the case of pedestrian injuries, then potentially the other three crossings of that intersection could be considered as controls if you wanted to get that detailed in your study. But there's a lot of overlap in the exposures each of those might have with traffic volume and pedestrian volume and things like that might complicate using those as controls. So some studies, what they've done is they might have one case that's linked to the case and another one that's not. One example of that in my past work was a study on pediatric window falls. So children that showed up to the emergency room because of falling from a window in Seattle, Washington, they were identified as cases, and then we identified a control from other children that were regular users of that hospital for other diseases not related to window falls. And then we visited the homes of in both cases, and within the case households, we examined the window, which was the true case of interest. We looked at window characteristics, and then we looked at another window in the household that had not had a window fall as one of the linked controls to that one. And then we also had the separate control child and was able to select a window in that household similar to the window from which the child in the other household had fallen from. So that's just one example. Um, so I mentioned confounding before, and so confounding refers to the relationship between disease and exposure being affected by another factor. So a classic example is, if we're looking at, cancer as our outcome. Sorry, that graphic actually is an error in it. It's just exposure. That should be outcome. Um, and our exposure of interest maybe is coffee drinking. Is that associated with some sort of cancer? Well, because cancer or because coffee drinking, at least historically, was linked strongly to smoking, if you didn't control or consider the role of smoking in your study design, you could have it confounded by smoking status because smoking is strongly associated with cancer outcomes. And so, what do you do in this case? Where we have this factor that strongly influences both exposure and our outcome. Well, one, we could sample from different levels of that confounder. So in the case of coffee and cancer relationship, we could have controls and cases that are sampled among smokers and then those that are from non-smokers. And that way we are stratifying our exposure and outcome by this confounder. And then you can adjust for that confounder statistically in different ways, or you can take it out of the equation by matching. So in the case of what's in coffee cancer relationship, you would take if you have a case that's come up with a cancer of interest, and you link that. You're trying to link that to coffee exposure, then you'd find controls that are also, if they're a smoker, then you'd find controls that are smokers or non-smokers in the case of non-smokers. So For matching, this refers to making sure that our controls or cases are similar to the cases on specific defined factors. And it's to help us eliminate the possibility that differences are due to that factor that we're matching on, like the confounder. So that matching factor should be strongly related to both exposure and the disease if we want to match on it. Otherwise, it's not really useful to match on it. Um, if we're also matching on something, we have to be sure that it's not going to add a lot of extra cost to our study or that we plan for that. Um, and it's particularly useful if we know that our exposure is going to cost a lot to obtain to match, because then it'll make sure our study more efficient, and it typically require lower numbers of participants to meet our sample size requirements. But there is the risk of overmatching. So if the factor that we're matching on is really only related to the exposure or the disease, then it's probably not going to help us in controlling for that factor as a matching factor. Or if it's in the causal pathway between our exposure and disease, that's also very problematic, and might induce a relationship. Typically, when we do matching, we match 1 to 4 controls per case. Beyond 4 controls per case is usually not statistically efficient. Once you get to 4, like even matching 4, is kind of above and beyond. And so matching at least 2 controls is typical if it's cost efficient. Maybe 3, and then 4 if it's cost efficient to do so. It adds a little bit more statistical power to your analysis. And so there's 2 types of matching. There's individual matching, where we have the individual cases and we're matching specific controls to those specific cases. Frequency matching refers to matching your overall case population to a control population that's similar on your characteristics of interest in the terms of the distribution. So say like you want to make sure that your control population has the similar age, uh, gender, and maybe race, ethnicity, education, income, whatever status that you want to match on, and they have a similar distribution of those things as your case population. And then you can randomly select your controls from that population. And then it's important to know that if you are matching on certain factors, that you won't be able to include those factors in your analysis because you've matched on them, and you're just kind of taking them out of the equation essentially, so you don't have to be concerned about their potential confounding relationship. And then this table here illustrates, how this setup is done for this type of study, where we have cases that are exposed and non-exposed and controls that are exposed and non-exposed. And really, the most important cases in this are the discordant ones. So the cases and controls in A and the cases controls in D. These pairs are the ones that really determine our odds ratio, because we're dividing this one by this one to calculate our odds ratio in that case. And really, the C and B cases don't matter. So, oh, sorry, no, I just said that completely opposite. It's B and C that matters, not A and D. So we're dividing these discordant cases of B by C to calculate our odds ratio. Sorry, I misspoke earlier. So A and D are the cases that are most important, are not most important, but B and C are those pairs. So an example of our 2 studies, in the Lima Peru case, in both cases we did some matching. In the Lima Peru study, we explicitly used matching as a risk set sampling, where we had a defined set of roads that were the same road type, the number of lanes, some are radiating roads, and a search radius within 500 to 1,000 meters of that location to identify that risk set for each case. And then randomly selected 1 control from those because of the cost of in-person visits to those locations. And then for the study in Delhi, 3 cyclists were intercepted at each case site at the same time of day that the crash case had happened on. Those cyclist routes they determined their origin, of where they came from. Those routes were mapped using Google Earth, they couldn't necessarily determine that for the fatal cases because the person had died, so they weren't able to determine, where they came from very easily. And then they selected one random control location from each route as each of those three routes as comparison. Okay, so when we're designing our study, we have to think about what is the sample size we need to accomplish, the to find the association, to examine the association of interest that we're trying to study. And so, for those that have had, some statistical training, some of these terms will be familiar for those that aren't. And, I recommend reading a bit more up about this. But basically, when we're looking at associations and the distribution of different variables and outcomes, we have what are known as type 1 errors, where we have an association that's detected, but actually does not exist. So it's a false positive. And we have type 2 error, where an association is not detected, but it actually does exist. And so it's a false negative. And so these two types of errors are really important for getting the right sample size in order to reduce the chance of these errors happening and affecting the validity and generalizability of our study. We also need frequency of exposure, particularly among controls, to calculate sample size, or the prevalence of exposure. We need the hypothesized effect size, or minimum detectable effect size, or the size of an important effect that we want to detect in our study, or hope to detect that's important. We need the number of available cases, and then we need, think about, for our study and our resources, like what the precision versus cost is of our study, particularly if we're doing matching. Um, so what do we want to calculate? Well, say like we don't know our sample size, like we don't have a defined number of cases, and so we want to estimate how many cases do we need to detect, some minimum effect size or odds ratio with a specified power. Or maybe we already have a sample size and an effect size that we feel like we have to detect a minimum effect size, so we can then calculate, well, what is our power to detect that? And then finally, maybe we have, a sample size and we have some steady power, minimum steady power, and then we can determine, what is the magnitude of association that we can detect with these characteristics. So as an example, well, not before we get to examples, how do we calculate these things? So first, for an unmatched case control study, these are the equations for it. You don't necessarily have to know or memorize or, be familiar with these entirely. I mean, you should understand them. But there's calculators that help us to make these calculations as long as we have these numbers here, which we just talked about in the prior slides. So we take our numbers we have here and we can put them into the calculators, and then it will provide the calculations for us. If it's a match case control study, then it's a little bit different calculation because once again, it depends on these discordant pairs. Sorry for my error before I described that. Um, and particularly increasing the ratio of controls can help increase the potential number of discordant pairs we'll find. And so that's why match case control studies, having more than one match control if possible, is usually better and more efficient. Once again, the calculators can also do this for us. So an example, if we look at the number of cases needed, we can calculate the number of cases, can calculate how many cases do we need. We can assume, we want a 0.05, alpha, which refers to the type 1 error. This is like our, confidence level. We want our power, this is our type 2 error, to be at least 0.80. So like, the 80% of the chance we can rule out that we detect an association that was a false positive. And then we need the prevalence of exposure among controls. And so then in our table here, we have, the minimum, odds ratio, that we might expect to detect in different scenarios. We have a prevalence that we might expect depending, if we don't know exactly, we can put in different values. And then the number of controls per case that we need, depending on how many cases that we get. So if we wanted just only one control per case, then we need 957 cases to detect an odds ratio of 1.5 and a prevalence with a prevalence of 10% of the exposure in the control population. So if we're looking at calculating power based on a number of cases and a minimum detectable effect size, then we need, once again, I said our alpha at 0.05. A number of cases might be 3,000 cases in this example, with a prevalence of exposure of 0. And so we our prevalence of it being these different characteristics here. So these are just some examples here of what they might be. I said 25% prevalent, 0.6% prevalent, 1.7% prevalent. Here's the minimum detectable odds ratios for this potential particular example, and then what power can we get based on these different characteristics. So if we have something that's not very prevalent, then getting high enough power, you probably need to start matching more cases. But even then, if we're not going to detect this lower odds ratio with that study characteristic of 3,000 cases. We need a lot more cases. And then finally, if we're just looking at effect sizes, we have, once again, our alpha set at 0.05, our power at 0.8. We have 2,500 cases in this example. And then our prevalence of controls with the exposure, are these levels here. So, for this study, because of the size of number of cases we have, we're able to detect a fairly low odds ratio here, even with only one match control. Okay, so how do we collect data for case control studies to make sure that we minimize selection bias, recall bias, and all those other things that we've talked about? So first off, we have to make sure that our controls are free of the outcome. That's part of our data collection process. We want to determine their exposure, in the past or before the outcome occurred. And we have to define, what our unit of analysis is. These are hopefully things that we've done, before selecting our cases and controls. But then we also have to consider, well, what is our access to the data that we need? Is this something that we can get from hospital records? We can do through retrospective chart, review. Do we need to call subjects up and try to determine their history? Do we go to locations and do an audit of these locations? Do we look at historical photos maybe if those are available? And then what is the quality of the data that we're using? Are these hospital records, are they accurate? Are they complete with what information we need, or these police records? Um, how are they recording all cases and the control population accurately? We need to think about what limiting our geographic area. We have to define that specifically. And then there's information bias and recall bias are things that are really important to consider because for the cases, particularly for interviewing them, they're going to be probably most likely trying much harder to remember exposures than the control cases are. So we have to ensure we have prompts to help the controls have a similar recall as the cases if we're doing that type of study. Or if we're collecting things out in person, we want to make sure that we're collecting that data in the same way at both case and control locations, that we're not biasing the cases in our data collection in some way because we know they're cases and we want to find something there. Um, And then we have to define our exposures very, very clearly so that, when we're recording things that there's no chance for error on and how we're defining what is an exposed or unexposed case and control. So these are just some examples of things of how we can of where we can find some of these data. Subject interviews are very common. For injury studies, maybe less so. Medical and morgue records are also very common, particularly for identifying cases, but sometimes they also have the data we need for case control studies. Insurance records can be very useful sometimes, and police records as well. Sometimes there's existing GIS, geographic information systems data from a city or country or other geographic unit or other authority that we can use for exposure status. Sometimes we have to go in person if we're doing something that's based on the road, like roadway safety. Maybe artificial intelligence can help us collect data too for some things, in some automated way if there's feasible data for it to review, like a chart review. So those are some examples. So how do we, just some general comments about, data quality of secondary records, particularly for these common sources that are used in a lot of case control studies of injuries. So for police records, it's important to note, these are typically focused on events, a crash, a crime, something that happened, that the police are determining, the legal implications of that. Not for determining, relationship between an injury and some exposure. Typically, so that's not usually the purpose of police records. And so the records might not have information that we need or find useful. Um, Police records also aren't often linked to later outcomes, particularly in low to middle income countries. So we might have very limited information on what happens to someone later. We might know that a crash happened at a specific location, but we don't necessarily know if it was fatal later on. We might know if the fatality happened at the scene or maybe shortly after the crash happened, but if it happened later, police records usually don't link to that record, unless there's some sort of separate database that's done that for them. And there's often missing data or limited data collected. As I already mentioned. And it's a possibility that police don't record all events, and so we must think, consider, whether, the police records are only recording maybe the most severe events. They typically get, a call to emergency services, and the police might show up to, to be on the scene for that. Maybe less severe things, or things that don't necessarily actually require like medical attention, might not even end up in the police database. If we're looking at medical remark records, well, these might be more complete than police records, but they often don't have a lot of information about the event or context of the injury. They might give us some sort of mechanism, oh, this was pedestrian crash, but we might not know where it happened or the type of vehicle or other factors about that event because they're focused on the medical care of that person. Medical records also, will probably only include more severe or fatal cases. They need medical attention rather than less severe cases that might be in the police records because they got the police attention. Medical records also can come with privacy issues that might limit access. If you're not part of that medical or health system, to be able to, set up a study to access those records, then you might not have a chance, or be able to do that very well unless you partner with someone that's based there. And then, this part can be issue in low and middle income countries. If you're collecting data across facilities, maybe only public facilities are going to be accessible, and private facilities may be less likely or less interested in sharing those data, particularly if you're not based at that facility. So, for example, for our two studies for this presentation in Lima, Peru, we made site visits to all the identified case and control locations. We would go as close as possible to the time and day of the week of when they happened, record their built environment features, took some pictures, use a speed gun to collect their speeds, and also video recorded the traffic to get later to get traffic and pedestrian volumes from them. And India is a similar type of approach: in-person visits to each location, video of the traffic, audit of the built environment features, and then they use Google Maps for the traffic speed estimate rather than the speed gun. So once we have our data, how do we analyze it? So estimating the odds of an outcome given exposure is what we're doing. We're calculating what's known as the odds ratio, which we go to our contingency table here, and we're multiplying across cross multiplication here. You do A times D divided by B times C to calculate our odds ratio from our crude odds ratio. And in the cases of rare diseases, they are approximate the relative risk or the risk ratio of that because of the way that those are calculated. And if we're using regression, then we use logistic regression for analyzing these. The outcomes is 0 or 1. In the match case control studies, we're using conditional logistic regression because that accounts for the matching between them, and we're looking at the pairs in that as well. We can account for some selection bias by adjusting for, those for the way that, cases or controls were included in the study. So we can do an inverse predictive probability, for example, that a subject would have been selected given data collected. So like if we had people that refuse to participate, then we can include them in somehow if that's an issue. We can also adjust for the factor associated with selection, using stratification or inclusion in the regression model. But if we have a lot of non-response, then that's less, we're less able to do that. Um, if we have measurement error, we got to consider that as well when we're, particularly when we're interpreting the study. Exposures far further in the past, have higher recall bias. If we're trying to look, 20 years back, like, is the person going to be able to remember those things, accurately enough to be of use for the study? For example, one study in Seattle looked at children who had been injured and followed up with the parents a year later to determine if they could recall those injuries happening. And overall, only 37% recalled any injuries 1 year later. Essentially, those with more severe injuries that had a bit higher recall, but even then, for those with major injuries, only 80% of them recalled their child's injury. The other 20% did not recall that injury happening. And that's a pretty substantial amount if you think about, the impact that could have on the way we're, examining our outcome and exposure. And so for sometimes, also for these studies, because we're doing retrospectively, like we're trying to collect data that's kind of related to like the event, we can't always get data about the event itself, that's important, like the traffic volume or the pedestrian volume, or there are other temporal factors at that moment. And so what we sometimes do is try to go to that place at the same day of the week and time, try to replicate those conditions and get a sense, for our data of like what that might have looked like, based on that, on those times of days and days of the week. But we have to recognize that's a limitation. So, for example, in these two studies, both of them, well, the Lima-Peru study used conditional logistic regression. The Delhi-India study used logistic regression. The Lima-Peru study focused on confounding, like with predefined confounders that have been hypothesized, and then exploring confounding from other factors, as well as checking for effect modification, where the relationship between disease and exposure. We're looking for variations, like for example, by road type. And then in the case of the India study, they used a stepwise backward regression approach to with their explanatory variables. They tried to account for multicollinearity, and they also did some sensitivity analyses. So, how do we interpret, our findings? We're trying to get at some sort of causality when we're doing a case control study. We're trying to establish a relationship between the exposure and the outcome. Trying to, with the assumption that we've collected them in some way that determines the exposure happened, before the outcome occurred. We got to consider the strength of the association. Just because something's not statistically significant doesn't mean there's not an association. There might be an elevated odds ratio, that suggests that there's an association, but maybe we didn't have the study power or sample size to truly observe that as statistically significant, observation. And we also have to consider, like how frequent is this exposure in the overall population? Like if it's a very prevalent exposure, then that ends up being something that is a little bit harder to interpret from odds ratio. But if it's a very rare one, then that can strengthen our observations sometimes. We're also trying to think about, like from our study results, like does this tell us about the cause of the disease, the etiology? How do we consider, what our results tell us about that relationship? We also have to think about all the limitations our study might have when we're interpreting things, like how well are the confounders measured, what we couldn't measure, other factors, that would have been influential. We have to think about like, how sensitive our study was to time, in relation to when exposure and the outcome happened, how generalizable it is to a larger population or even to the source population. If excluded data, like what are the potential impact of those things on our study interpretation? How good were the data we used? Did we look at multiple exposures? If we start looking at a lot of exposures, the chance that we find a statistically significant exposure increases because we're looking at more and more comparisons between things. And then we have to consider the accuracy of the reporting of our subject as well. So these are some of the example results from these two studies. The pedestrian study in Lima looked at pedestrian signalization in this part of the study. Didn't really find any statistically significant associations overall in some of the pedestrian signalization stuff. You maybe find an elevated risk. Probably needed a little bit larger sample size to better determine this. In the Delhi study, similarly, motorcycle and car volumes were associated with bicyclist injuries. With higher motorcycle volumes, we had a lower risk of bicyclist injuries, or fatalities, whereas the car and van volume increases led to or were associated with a higher risk of bicyclist fatalities, as we're being near intersection junctions. So what are some alternatives to the standard case control design? So a popular one is the nested case control. This is where we have some existing cohort of units of analysis. Might be like a group of workers or existing like prospective study. It could be in the case, as we mentioned earlier, like a set of roadways in a city. And so what we want to do is collect additional exposure information that we might not necessarily have available at our fingertips. And we're doing a nested case control rather than like a full like cohort study because of cost efficiency. We can't collect exposure on everybody or everything. And so we're only identifying the cases within that cohort, not anything outside of it. And then we find controls that are matched, perhaps to that case in terms of either the having similar characteristics or who were part of the sample, part of the cohort at the time of the injury happening. Or we can do a case cohort approach where rather than trying to sample, get all the cases in the cohort, we just do a sample of the whole cohort to get a small proportion of it, whatever we need to meet our sample size requirements. And this is particularly of interest, if we're looking for time to event, where we have the cohort, we had a start time, and everyone has some more follow-up, then we can get the end point or censoring for that person, if they died or left the cohort that way, to calculate a hazard ratio or relative rates. So this is also efficient for getting exposure info on a smaller sample. We don't need time match controls for this one. We just run, we can use the full sample rather than looking for people that were part of the cohort at the same time as the original case. So it doesn't matter when they entered or left. We're looking at their overall time. But we need a specific outcome for this that hopefully we get a large enough subsample that includes enough cases to look at this relationship. Then there's the case crossover design, where cases serve as their own control. Um, and But the way that the controls are selected and the cases are defined is by time. And so we have an event that happens and we put a set of time around that event that defines that as an event type time period. And then we have non-event time periods, might be before or after the event, depending on, how, on the sampling that we can do with that. So we want to define very well like what the event is. So in this example here, this is looking at the injury related to alcohol consumption and later cannabis use, and then the relationship between them. And so, the person serves as their own case and control for this. They We might start 24 hours before the injury, and then we might have a time period of alcohol consumption, cannabis use, and then when the injury happens. And so this is how they define that case crossover for the study of these different time periods at risk, not at risk. Um, so usually these studies, are more effective for short-term effects. So injuries fit very well into this paradigm. There's been quite a few injury studies that have used this. And it's nice because the case and control is automatically matched. But there's still, limitations due to recall bias, if we're interviewing people about when, they, to determine their exposure status at different times, that can also be an issue. That with in-person confounding from, different behavioral factors of that person within that person. And then finally, there are case-only studies where we're comparing case subtypes to look at some sort of, cause of disease heterogeneity. And so we might be trying to examine, some exposure effect modification, So like, say, like in the United States, there's the fatality analysis reporting system that's been used for, hundreds, if not thousands of different road traffic safety studies over the past, 5 decades. Um, and these are really all fatal cases, that are in that database, but it's been used for many studies to compare, differing alcohol levels and risk of death, among, like passage of the same vehicle or seatbelt use or pedestrian injuries by age and impairment. So these are some examples of that. And so they can also be useful studies that are kind of related to the case control design. So some two examples of these alternative case designs. One is the Brazilian steelworkers, who were a nested case control study. The cohort of them was over 21,000 men that had been employed at a steel plant in Brazil between 1977 and 1990. They were followed up to 1992, used their medical records to identify them, or their employment records, plus medical records. Sorry, I don't remember that from the study. And the cases were those who had died from an injury related to work, and the controls were those who were employed at the same time of that person's death. And they used a 4-to-1 control ratio to study that. In terms of a case crossover design, on this on the right, they were looking at cycling injury risk for different route types. And so the study population that was used to identify the locations were 690 injured bicyclists in Toronto and Vancouver, Canada. From the cyclists, they could identify the case time and location as like when the cyclist motorist crash had happened. And then through interviews with the subjects and audits of the locations, they were able to look at non-crash locations along that cyclist route to compare them to their event when the crash happened. So those are just two examples. So in summary, case control studies are extremely useful for rare outcomes. So injuries fit well into that paradigm, and for low prevalent exposures. Once again, injuries also fit well into this. They can be readily applied to study injury outcomes and exposures in low-income countries. Because of that, and they're usually lower cost than doing, prospective cohort studies. But it's important to be aware of the data quality and completeness issues that we mentioned, as well as the recall. Um, you know, Applying them in all settings may not always be appropriate. If you can't really identify the cases, then you might need to think of a different way of moving forward with your study. But typically, I think there is a way to do them in most of the locations that you are based in. Um, and um, and it's really important to consider, that these are typically very low cost studies because of the amount of effort that's involved in it. But it does require some person time and, of course, knowledge of analyzing the data and collecting the data appropriately to make them successful. And with that, I'll end the lecture, but looking forward to hearing any questions or comments that you might have in the future on this. Thank you.